Sounds great. Hello and welcome, everyone. We are happy to see you today on this lovely, windy Thursday. My name is Allison Elsner. I'm the CEO at the San Bernardino County Medical Society, and we are very delighted to welcome you to the third in our clinical education webinar series through San Bernardino County Medical Society in partnership with Riverside County Medical Association and IEHP, Inland Empire Health Plan. And I think many of you know that the purpose of this webinar series is to create a bridge between primary care practices and specialty and subspecialty practices. A lot of times it's difficult for primary care physicians and providers to have all of the resources and tools that they need to effect proper referrals and a comprehensive treatment plan. So that is our goal here, and our wonderful guest speaker today is going to help us with that particular topic in the area of allergy and immunology. So with that, I would like to introduce our guest speaker today. Christelle Miot, MD, is an assistant professor of medicine at Loma Linda University, working in the Allergy and Immunology Clinic. Dr. Miot graduated from Loma Linda University School of Medicine and finished her residency in internal medicine also at Loma Linda University during the COVID years before doing a fellowship in allergy and immunology at Barnes Jewish Hospital and Washington University in St. Louis, Missouri. She then returned to Loma Linda to work for Loma Linda Faculty Medical Group as a board-certified allergist and immunologist. She subspecializes in drug allergy and mainly sees adult patients. She loves education and mentoring medical trainees, and we are very happy to have Dr. Miot with us today. Welcome, Dr. Miot.
Hello, everybody. I am glad to be here, and thank you for the invitation. And so this is my first time here, and I felt the warmth, so I really appreciate it. And I also want to welcome everyone who's here to listen, and hopefully we all learned something today. I am going to share my slides, and let me see if we can do that. So. All right, how are we doing there?
That looks great.
Beautiful.
We have your main screen on. It looks like it's not in presentation mode, but that's no big deal, Dr. Miot.
How is that?
Yeah, we've got the.
All right.
Yeah, it's fine.
We'll make do for now.
Yeah, absolutely. Looks great.
Very good. All right, so as we said earlier, my name is Christelle Miot. I'm an assistant professor here at Loma Linda. So our clinic mainly treats adults over 18 years old. So today's recommendations will focus on that. However, allergists, whether they're adult or pediatric trained, we all follow the same guidelines published by the QuadAI, the American Association of Asthma, Allergy, and Immunology. And so for today, we're going to go over some updated recommendations for some common allergic conditions by talking about how allergists and primary providers can assess and plan for these patients and share what services are available at your local allergy clinic. We're going to talk about some referrals, some inappropriate referrals, or I like to say more efficient use of resources or referrals that may be best sent to a different subspecialist. And we're going to briefly go over e-consults and review the current available literature, and then we're going to conclude afterwards. I have no disclosures. So the main conditions typically seen by the allergist when it comes to airway diseases, they are rhinitis, allergic and non-allergic, asthma or reactive airway diseases, and chronic rhinosinusitis with or without polyps. Other conditions that are usually co-managed with another subspecialist would be something like ABPA or allergic bronchopulmonary aspergillosis. Typically, we share that with pulmonology, and AFRS or allergic fungal rhinosinusitis, which we share with ENT. Skin testing is helpful in establishing a IgE-mediated hypersensitivity when a patient has symptoms that correlates with known allergens. The skin test is immediate, and patients are able to discuss their results right away during that same visit, unlike serology with RAS testing, where they discuss these results afterwards. And we can talk about the allergens and how to avoid them during the visit. The test itself does not require any preparation, except for having the patient hold any PO or intranasal antihistamines for 5 days. We require that they hold any PPIs for 3 days, and LRTAs like montelukast for 3 to 2 days before the skin test. The skin test itself is painless and takes about 15-20 minutes, where the antigens are applied on the patient's naked back and sometimes on the arms. Every once in a while, we need to do intradermal testing that may be needed, which is very similar to a PPD test if the patient has ever had one. That one may have some pain associated with it. Skin testing is relatively sensitive with a little less specificity, and that is because up to 30% of patients can be sensitized without allergic disease to aero allergens, but 60% of those can develop true allergies later. I call it a potential to be allergic when there is no symptoms with it. There is no gold standard for IgE testing, and it's a little bit unfair to compare some different assays. And clinically, there is no specific cutoff for that is consistently considered significant. We make the correlation clinically instead. The goal of the skin testing with an allergist is to start allergy immunotherapy or AIT. Allergy shots or subcutaneous immunotherapy or SCIT or allergy immunotherapy. It's been demonstrated to significantly improve a patient's quality of life and reduce medication use. It helps prevent the development of allergic asthma if started on time. The question always comes up about shots versus sublingual immunotherapy. And in my personal experience, SCIT or subcutaneous has been a lot better and makes more sense for multiple reasons because the patients are polysensitized. They want to be desensitized to several aero allergens, whereas sublingual tends to be one at a time. Insurance also tends to cover it more. SLIT or sublingual is contraindicated in patients with EOE and has best data for dust mite allergies, which we'll use in atopic dermatitis. And SLIT or sublingual is only available for dust mite, ragweed, northern grasses without Bermuda grass, which is a very common grass. Regarding asthma, allergic asthma, meaning asthma specifically triggered by aeroallergens or sometimes food allergy, this is also a clinical diagnosis with studies like PFTs that can help in the diagnosis. GINA guidelines have been updated the past few years where it is now recommended to add ICS to the SABAs, so a steroid to the bronchodilator, as the alternative treatment for rescue with ICS LABA, something like Symbicort, for example, or Brena, as first line for rescue rather than the SABA alone. We use a smart approach in many patients, single maintenance and reliever therapy. There is one study that talked about how the SMART approach specifically uses ICS formoterol as both the maintenance inhaler and the reliever inhaler. It titrates additional ICS together with additional formoterol against breakthrough symptoms when symptoms prompt reliever use, which significantly reduces the risk for severe exacerbation, defined as an emergency room visit, hospitalization, and the need for corticosteroids for 3 or more days, compared with maintenance ICS or ICS LABA with SABA reliever. All right. So in terms of treatment, this is to remind that LRTAs such as montelukast are to be used as second, if not third line for airway diseases, with less convincing data, at least in adults, though some patients can still have some improvement. Because of the low side effect profile, we tend to prescribe it a lot. However, there's some data that has now required a black box warning by the FDA because of psychiatric dysfunction. We tend to see them more in young patients with underlying mood disorders. There were two studies from Korea and Denmark that saw it in younger people, but a more recent paper from JAMA had a hazard ratio of 1 in their peds population. But in my experience, adults with this side effect usually will say that they have very vivid dreams and increased irritability, whereas the black box warning specifies suicidal ideation in young patients. Systemic steroids are only to be used in exacerbations rather than maintenance, with doses and duration varying between the different studies. With the smart approach that we just talked about, we are now needing systemic steroids less and less for exacerbations. If a patient is in need of systemic steroids for maintenance, they should probably be evaluated by an allergist or a pulmonologist, especially if no biologics have been tried. Biologics are now used a lot more frequently because of their low side effect profile and now increased availability. Insurances are covering them more and more. Dupilumab is an IL-13 and IL-4 receptor alpha blocker. Omalizumab is an IgE blocker. Mepolizumab and benralizumab both bring IL-5 blockade for eosinophilic patients who have airway disease. These drugs are finding new indications these days for allergic diseases, so we're practically putting it in the water this time. Your local allergist will offer skin testing for air allergens. They'll follow that with allergy immunotherapy if that's indicated, and the biologics will also be managed by the allergist. And it is recommended that the patient gets their shots continually at their allergist instead of the PCP's clinic because of the monitoring that it requires for at least 3 to 5 years for the full effect. Now, urticaria, this is a common diagnosis with acute urticaria less than 6 weeks happening up to 20% of the population. It is self-limited, self-resolving, usually from either a drug or food allergy most of the time, and sometimes transient from an infection. Up to 50% of the time, no trigger is found, and we say it's probably from a transient asymptomatic viral illness, very non-specific. Chronic urticaria, on the other hand, or chronic spontaneous urticaria, up to 1% of the population can have that. It lasts over 2 weeks. It's spontaneous and no trigger usually will be found. Now, the mast cell has multiple receptors that can lead to degranulation of histamine and creation of hives and swelling. We think it has to do with an autoantibody that can trigger it. And sometimes the symptoms of chronic urticaria can precede the diagnosis of an autoimmune condition. No testing is needed for chronic spontaneous urticaria. It is also a clinical diagnosis. It just requires classic hives, urticaria, not dermatitis, lasting over 6 weeks. Some alarm signs, however, may require further testing. And they will include things like bruising of the skin, and again, urticaria, not dermatitis, lasting more than 48 hours, some post-inflammatory hyperpigmentation, some associated systemic symptoms that are more suggestive of autoimmune disease, especially vasculitis. So then testing can be useful, especially biopsy. So the testing will focus on looking for cytopenias, liver disease, inflammatory markers. A TPO antibody can also be looked for because it's the most commonly found autoantibody found in chronic spontaneous urticaria. Every once in a while, I'll also get a total IgE as a predictor of how well they may respond to omalizumab. And a D-dimer sometimes can also help testing for high activity of the urticaria. CSU is managed with high-dose antihistamines, up to 4 times the daily dose. And occasionally we will add a H2 blocker as well. And notice that allergists will increase the H1 blocker here. Things like cetirizine or loratadine will increase it there up to 4 times the daily limit for urticaria, but we don't tend to do that for rhinitis. LRTA, like Montelukast, can also be added on there because it is believed that some patients can have an underlying imbalance of their COX pathway versus leukotriene pathway. And these patients usually will have NSAID exacerbated urticaria, and we recommend that they use celecoxib instead of COX-1 inhibitors for pain. Omalizumab is the only biologic that is approved for chronic hives, and dupilumab is currently under phase 3 trial for this condition. And patients can have some relief with omalizumab as early as 46 weeks, and they can start tapering off their high-dose antihistamines within 2 months. But 50% of patients with chronic hives will have it for a year or longer. Now, food and drug allergies are some of the main referrals for allergists. Food allergy affects 8% of children in the US, less than 5, and about half of that percentage is also found in adults. Food allergy can be IgE mediated and non-IgE mediated. So IgE testing should only be offered in the correct context. IgE testing, whether it's serology by the PCP or skin prick by the allergist, correlates with a probability of clinical reactivity, meaning it gives us a sense of how likely is this individual to react rather than a slam dunk confirmation of an allergy. This isn't like your A1C test with a diagnosis of diabetes. The gold standard for a food allergy is actually the challenge rather than the IgE testing. The specificity of IgE testing for food is 50%. And so we don't recommend food panels. Please avoid food panels. Targeted or directed testing is recommended instead. Broad testing with food panels can be harmful, especially in children where the child or their parent may unnecessarily avoid multiple key foods. They create anxiety around foods and they restrict the diet for several decades. And it actually has been demonstrated in the pediatric population that avoidance of a food after sensitization can actually induce a true IgE-mediated food allergy. If it's not clear, it may be best to have the allergist order the test in some of these circumstances. Just a quick word regarding EOE or eosinophilic esophagitis. It is also recommended for these patients to see an allergist, and we co-manage them with GI and give some guidance with food avoidance, and we can also manage dupilumab. Sometimes they may find it a little bit easier to follow up with the allergist rather than the GI doctor since their clinic is a little bit busier. Now, regarding drug allergy, we're going to talk about penicillin allergy specifically. So 10% of patients reported penicillin allergy, but 90% of those patients actually tolerated just fine. And we're avoiding penicillin for no good reason for a lot of these patients. Penicillin is first-line treatment for multiple types of infection. And so the penicillin allergy label delays appropriate treatment with antibiotics, and the clinician just ends up using an alternate antibiotic instead with increased risk of resistance, inadequate response to treatment, higher risk for side effects, adverse reaction. There's some studies that show that the allergy label just on its own has a higher risk of hospitalization, respiratory failure, intubation, ICU level of care, and mortality. And so there's a lot of adverse reaction associated with just having that label. In assessing the patient in the primary care setting, it is good to understand whether the patient presents with an IgE-mediated reaction, such as urticaria, anaphylaxis, or non-IgE-mediated reaction, something that's more delayed, like dermatitis or even Stevens-Johnson's. And these things happen weeks later. Skin testing is useful mainly for the IgE-mediated reaction. So a referral to an allergist for any patient with just the penicillin allergy label is a very good choice because this patient can have evaluation while they are well because it can significantly alter their treatment course in the future. A family history of penicillin allergy, please go ahead and feel empowered to delabel the patient. That one, you don't even need to send them to the allergist. So the PenFast tool was established after studying about 600 patients with a penicillin allergy. So these patients prospectively underwent allergy testing with skin prick testing, intradermal testing or patch testing, and a challenge. So the PenFast just requires 3 clinical criteria. We need to know the time from the last hypersensitivity from penicillin, what reaction it was, what kind of symptoms they had, and if there was any medical treatment needed for that reaction. And based on those details, the PenFast risk tool will determine if the patient is very low risk, less than 1%, low risk, less than 5%, which is the average population, moderate risk of a positive allergy skin test, 20%, so more than the average population, or high risk at 50%. The negative predictive value for the PenFast tool is 96%, which I think is pretty good. And this is what the PenFast tool looks like. I want you all to feel empowered to use this tool. It relieves multiple burdens on the healthcare system. And if there's ever the slightest of doubts, you can always do a referral to a local allergist because we are passionate about this. Now, once there is a diagnosis of a food allergy, the patient needs to have strict avoidance and guidance for avoidance because of cross-contamination, and they should be given an EpiPen for anaphylaxis with instructions of when and how to use it. With drug allergy, the patient needs strict avoidance, but a lot of the drug IgE wanes over time, so a patient may need to see an allergist again to evaluate whether they have outgrown the drug allergy and delabel them. With food, this phenomenon may happen in toddlers and young children with egg and dairy, less with peanuts, and much less with adults. So revisiting the allergist is important after the diagnosis is made. Omalizumab is now approved for patients with multiple food allergies. So the Outmatch study, which was published in our journal JACI in February of last year, had as its primary endpoints the reduction of allergic symptoms from accidental exposures, anaphylaxis, and it is for that rather than a cure to food allergy. So those patients will still need to avoid their triggering foods. Oral immunotherapy is available, but only for peanut allergic patients less than 17 years old, without EOE and without uncontrolled asthma. Your local allergist may offer skin testing, followed by a graded challenge for the high-risk patients with IgE-mediated food and drug allergies. Skin testing is now not recommended for patients with low risk, with a low risk pattern with drug allergies, with a direct challenge being the gold standard for diagnosis instead for the label. A graded challenge without skin testing can still be used for intermediate risk patients, and your local allergist will be able to do that in their clinic. If the patient still needs that drug as their first line, for example, penicillin allergic pregnant women who have syphilis, for example, these patients need to have desensitization, though the patient may need to be admitted. Typically, we are not able to do that in the clinic, not always. Patch testing is offered for delayed and non-IgE mediated reactions. The way that works is we place a prepared allergen directly on the skin and we observe it several days later, sometimes up to 10 days for delayed reaction. And patch testing is a common question. Where does the patient go for this? It can be offered by a local allergist or dermatologist, depending on the allergen. Not all drug patch testing has been validated, and food patch testing even less so. Skin allergens and some of the topical drugs, such as steroids, can have patch testing performed by the allergist and the dermatologist alike. Here at Loma Linda, our clinic has not implemented patch testing yet, so a little bit of investigation may be needed before sending the patient so that they can go to the right clinic. So to recap on biologics real quick, here are some indications for referral for a biologic. So dupilumab has been approved for moderate to severe eczema, chronic rhinosinusitis with polyps, especially if they've had surgery and the polyps have returned. Persistent asthma with eosinophils up to 150 and or persistent asthma who are still needing prednisone and systemic steroids, and EOE. So dupilumab or Dupixent is recommended for those. And right now it is on phase 3 trial for chronic urticaria. It's due for an update actually tomorrow after I looked it up yesterday. Omalizumab is recommended for persistent asthma, also chronic rhinosinusitis with polyps, and multiple IgE-mediated food allergies. So if you see a patient with food allergy, they're allergic to peanuts and cashew, for example, these patients are eligible for omalizumab that your allergist can see. Omalizumab is also recommended for chronic urticaria refractory to high-dose antihistamine. So if the patient has been on cetirizine 4 times per day, they're still having urticaria, omalizumab may be the next step. Mepolizumab, IL-5 blocker, is recommended for hypereosinophilic syndrome, EGPA, and persistent asthma, also with eosinophils. Benralizumab, an IL-5 blocker, is also recommended for patients with persistent asthma with eosinophilia. I also want to mention tezepelumab. It's one of the newer biologics that is now approved for persistent asthma with and also without eosinophilia. So if those patients have asthma, but you are not getting any eosinophils at all, they won't be eligible for any of the 4 that I just mentioned, but they will be eligible for tezepelumab. It is currently under investigation for some other indications at this time, so we may have a few things coming down the pipeline. Switching gears a little bit, we're leaving the allergy world behind and now talking about immunology. So adults with primary immunodeficiency, sometimes they'll appear perfectly normal with some exceptions. It usually will reveal itself with opportunistic infections, recurrent infections, occasionally with autoimmune disease, and rarely with lymphoma. Pediatric patients with primary immunodeficiency or PID, they will often appear a little less normal, sometimes with congenital conditions, sometimes with facies that may hint at a PID. Until 2010, there was actually no screening available, but now with newborn screening, with nearly all the states, SCID in the pediatric population is now picked up pretty early on in infancy. We use the Jeffrey model 10 warning signs as a review of system for adults and for children under 12. With 2 out of 10 questions being positive, there is actually a pretty decent sensitivity and specificity for primary immunodeficiency in those patients. Some of the questions with the best evidence behind them are a family history of primary immunodeficiency, a family history of consanguinity in some cultures, so that can happen, and the need for IV antibiotics to clear infections, but that does not include ceftriaxone in the ER, for example. It is important to rule out secondary immunodeficiency with HIV testing, liver disease, myeloma testing, and also prior history of rituximab or B-cell depleting therapy in some patients, especially in the adult population, because primary immunodeficiency tends to be more present in children because of its association with these other congenital conditions and or monogenic causes of primary immunodeficiency. In adults, CVID or common variable immunodeficiency is more likely. It is less associated with monogenic causes. Once the pretest probability for PID is established and we've decided that we need further testing, we start investigating the immune system. I usually separate the immune system into the main components. So you have cellular, you have humoral, and you have the innate immune system. For the cellular part, we check for lymphopenia by testing T, B, and natural killer cell levels with flow cytometry. We check the humoral system with IgG, IgA, and IgM levels. There is no need to test for IgE. We already left that in the allergy world. And there is no need for IgD testing in primary immunodeficiency. We can use the IgD test for other reasons, but not for PID. There is also no need to check for IgG subclass because a single or isolated low IgG subclass level is less likely associated with immunodeficiency. There's a lot of redundancies in the immune system. The innate immune system also has redundancies, and it can be associated with multiple different things. So we assess that by getting just a regular diff to look for neutropenia, or you can do complement level checks. If these are negative, but we're still convinced that this person has a PID, the pretest probability is still high, and the patient has had a lot of recurrent and established bacterial infections, function testing can be the next step. So the way we do the function testing is with lymphocyte proliferation. We send that to the Mayo Clinic. And we assess the function and memory of the humoral system by looking at post-vaccine titers, 6 or more weeks after vaccination, especially if the patient has had their PPSV23. There is some question now with the new PCV20, what should we do? How do we manage that? That's still currently under investigation, but most of us right now, we're still going by the PPSV23. Monogenic causes of primary immunodeficiency, now we're calling those inborn errors of immunity or IEI, they're a lot more frequent than thought. So genetic testing is now being favored, especially in children and in young adults with any combination or more than one of these things. If they have immunodeficiency, autoimmune disease, severe atopy, or hematologic malignancy, any combination of those kind of prompts you to look for IEI. In a 2022 study published by Jackie, they had 123 patients with immune dysregulation or autoimmunity, endocrine disease, GI tract disease, and up to 39% of those patients had a specific germline mutation which helps in targeted treatment. I was training and I got a patient that had a STAT1 gain of function. They treated her with a JAK inhibitor and it fixed a lot of her symptoms. So these things can help with prognosis, they can help with surveillance, and they help with targeted treatment instead of doing something like rituximab for some of those patients. Again, a whole lecture can be had regarding immunology and genetics. There's a lot of wonderful things happening in that world. Now, these conditions are treated depending on the etiology. So for isolated cellular immunodeficiency where the CD4 is less than 300, this is treated off-label with prophylaxis antibiotics. Usually we use HIV guidelines for those patients. This is a very rare condition. It's usually instead what we find is combined immunodeficiency with humoral immunodeficiency, things like CVID. We treat that with immunoglobulin replacement therapy or IVIG or with sub-Q IG. Immunoglobulin replacement therapy is not titrated to a goal IgG trough, but rather a biologic trough, meaning that they are given the dose that is needed to keep them infection-free. And it is recommended for these patients to be empirically treated with antibiotics for a suspected infection, but a diagnosis we need to establish a diagnosis first to help the immunologist. It is important to culture something or image something to establish a true infection versus allergic bronchitis, for example, because the immunologist will need this data. They will use this data to decide whether to increase a dose rather than going by the frequency of antibiotics. Adults with CVID are still recommended to have all their indicated vaccines because we believe, again, there's redundancies in the immune system, so we still recommend them. Children with SCID and some of the primary immunodeficiencies will have strict contraindication to live vaccines, and they have to be seen by a pediatric immunologist as part of a multidisciplinary team to discuss the treatment. And sometimes for children, it'll include a bone marrow transplant or gene therapy. A lot of things are not available for adults with PID, but for children, it tends to be a lot different. Universal precautions are always recommended, and we still recommend also a referral to a geneticist, especially if monogenic causes of primary immunodeficiency are detected, because the next generation will want to know what is running in their family. Your local allergist and immunologist may offer testing, and they will manage their immunoglobulin replacement therapy. IVIG or sub-Q IG will be dictated, unfortunately, by insurance, and so we don't get a lot of say when it comes to that. But patients with more severe presentation that need replacement right away, they will need IVIG at an infusion center rather than sub-Q, because sub-Q replacement is a little bit slower. The allergist and immunologist will also order genetic testing and can do some interpretation, but it's best to connect them to a geneticist, which is actually available via NVT and LabCorp, who does our primary immunodeficiency testing. I want to go over briefly some appropriate consults that are not discussed today that will still require an allergist. So things like systemic mastocytosis and idiopathic anaphylaxis, please send those patients to us. Stinging insect hypersensitivity, so bee allergies. So those patients who are anaphylaxed from bee stings and who need venom immunotherapy, they need to be sent to us. Eosinophilic diseases like EOE, EGID, and hypereosinophilic syndromes benefit from an allergist. HAE, hereditary angioedema, so swelling that does not respond to any high-dose antihistamines, will be evaluated and treated by an allergist, and the need for drug desensitization. Now, patients who may be appropriately helped by a different service, those are things like urticaria, because urticaria is self-limited, needs no testing. And once the history clears a specific allergen, we can establish that this is simple acute urticaria. The patient will just need some reassurance and some medication. No need for an EpiPen if there is no allergen at all, especially if carrying the EpiPen will create more anxiety for the patient. Chronic rashes, especially dermatitis type rashes or new onset rashes in the elderly, sometimes they may best be served by dermatology, because if they can use a biopsy, that'll be more helpful rather than skin testing, which is for IgE mediated disease. Having the patient take some good photos is helpful. Food intolerances, things like non-celiac gluten sensitivity or IBS, unfortunately will not be helped by the allergist because there is no testing validated for these conditions. A referral to the allergist can help answer some questions for the patient and help in education, but the patients usually just end up feeling very frustrated at yet another fruitless visit. And so they can be best served by a nutritionist or a GI doctor. At this time at Loma Linda, we do allergy contact dermatitis evaluation, things that include like metal or cosmetics. The patients who need patch testing for those are sent to the dermatology department. So check with your local your local allergist first to see if patch testing is something that they're offering in their clinic. I also want to remind that not all that is dyspnea is asthma, as we all know. So patients with a known smoking history and COPD without atopy, patients with post-COVID breathlessness, patients with vocal cord dysfunction, we don't have testing available to the allergy clinic, and it might be more helpful with them for them to see someone else for the first step in investigation and treatment rather than allergen. I want to briefly talk about e-consults. So e-consults are electronic, they're asynchronous, clinician to clinician communication at a distance, relatively new tool to improve access to subspecialists for primary care providers. The idea is to reduce consultation time, reduce fragmentation of care, and speed up the diagnostic workup process for the patients. So the studies that look into e-consults, they're all retrospective, and many of them are single center studies. There was a Project ECHO that was done in 2017 where community clinicians got access to a multidisciplinary team for HCV management. And the model for that study found savings as high as $1,300 per patient compared to a regular referral system. And they also found that out of that A1C values improved a lot in their diabetic patients, even though it was mainly for HCV management. I personally think it was having a whole team with a collective brain that helped. I don't know if it was the e-consult per se. But the benefits in general for e-consults were modest, with mixed results from the clinician perspective. The benefits that were found included improved access and timeliness of the response, but there are some risks and concerns. There was quite a lot of those. And so they talked about the differences in management styles, disruptions to already established and working relationships, and there's some significant burnout. And the major barriers are actually lack of incentives for the subspecialists and insufficient reimbursement. Go figure. Technological challenges were listed in the study from 2019, pre-COVID and telehealth, but I would assume it probably has improved by now. So, all right. So to conclude, here at Loma Linda, we are here, we are available, and we are here to help. And we have our contact information. I can definitely forward it to anyone who needs it, but we are available. And again, we are here to help.
Well, that was fantastic, Dr. Miot. Wow, that was really very in-depth and such valuable information from a clinical standpoint. So I see we have a really good turnout too. So I think everyone has appreciated this. We are eager to accept questions for Dr. Miot. And I'm just trying to find my chat here. I'm not sure if any questions have come in. I don't see any. Does anyone have any questions you'd like to ask verbally? You can raise your hand or just speak up online if you do. As we sniffle. As we sniffle, the wind was that's crazy. Yes, go ahead, Dr. Chandrasekhar. Hello.
Hello there. I think there's a question in the chat as well, but I don't know if you want to answer that first, and then I can ask my question as well.
Sure, that's from Janice. So why don't you go ahead and go first, Doctor?
Okay, perfect. So my question, we see a lot of atopic dermatitis in like primary care, and oftentimes we're fairly confident in managing those, and most of the time it can be managed just with, emollients, topical steroids. But if for cases that are not responding to those, is it appropriate to refer to allergy, or is dermatology more appropriate in those cases?
It really depends. So for those patients, again, to just kind of recap, what do we do with patients who are refractory to topical steroids who have a little bit more advanced atopic dermatitis? Do they go to allergy or dermatology? It depends. If the patient has a collection of atopic conditions, which I assume they would if it's that advanced, usually if they have associated asthma, seasonal allergies, then yes, send them to the allergist instead, because it's a one-stop shop for them. We'll take care of everything. But if they have no asthma at all, no food allergies, nothing, just pretty advanced or very difficult to control atopic dermatitis, dermatology will be more helpful. But if you send them to allergy, just as good. I think it has to do with access. Sometimes it's a little bit easier to see the allergist first here at Loma Linda because we have a little bit better access than the dermatologists do. But if it's isolated to just regular, just eczema on its own, I would say dermatology, but if there's a plethora of atopic conditions, allergy.
Thank you so much.
Great, thank you. And I see Dr. Brian Wolk has a question here. He's there at Loma Linda with you as well. His question is there any testing you'd like to see before a referral for angioedema without a definite cause?
Yes, that is an excellent question. So if there is angioedema that is completely isolated, we are not able to get anything from the history, there's two tests that we could get, and it depends on when we're getting those tests. So if the patient is acutely having a reaction then and there, a C4 can help rule out hereditary angioedema. It's an extremely, extremely rare condition, but a C4, when obtained during an acute attack, it has a sensitivity of practically like 95, 99%. And so that will help rule out hereditary angioedema, which most of the time is unlikely anyway because of the rarity of the condition. The other test that can be helpful is a tryptase level. So the tryptase level is something that we like to get as allergists because when the patient is acutely ill, they're having a reaction, a tryptase obtained within 4 hours of the reaction helps us a lot to determine whether there has been mast cell degranulation. And so that will have implications for anaphylaxis and things like that later on. It is a send out test. It does take a while to come back, but a tryptase can be helpful in an acute setting, especially if there's urticaria, if there's other systemic symptoms, then yes. But more importantly, with angioedema without cause, I always want to trial the patient on high dose antihistamine. It is both diagnostic and therapeutic because if the patient responds to high dose antihistamines, meaning 4 times the daily recommended dose, then that's histaminergic angioedema. Then there has been mast cell degranulation. Then this is just urticaria without hives. But if we've done high dose antihistamines, there's no response at all. It makes it a little bit more suspicious for hereditary angioedema, and further testing may be warranted. But those two tests, to reiterate, would be a C4 level and a tryptase level.
Thank you. Just one clarification. I do see patients in the emergency department, so it is a test that we could get when they are symptomatic. The C4, if it was hereditary angioedema, would that be low, high? How do we interpret that?
Yes, the C4 would be profoundly low if it is hereditary angioedema. Profoundly
Thank you very
low.
much.
Mm-hmm.
Yeah.
Okay, and I see that Ms. Janice, you did have a question, but you've deleted it, but I'm going to ask it anyway. It's something we were talking with Dr. Miot about before the presentation started, and that is a little bit more from a lay perspective, but as far as with all of this kind of volatility with the weather and the hot and cold and wind, is there anything that you do advise primary care physicians to do for their patients who come in complaining of this, or do they need to be referred out?
So there is something that can be done by the average person without even needing a doctor, and that's by using over-the-counter intranasal sprays. I have a little speech that I give to every patient, and I'll give it to you guys. So our intranasal sprays, there's two types. So we have the steroids and we have the azilastine. Flonase works great. It works long-term, but you have to be patient with it. If you are going to use Flonase, you have to use it every day and be patient up to 2 to 3 weeks before you notice the full effects of the Flonase. If you know you are sensitive to extreme weather changes, start 2 weeks before spring starts. Start taking it regularly so that by the time the weather is going pretty crazy, you've already had enough Flonase in your nose for a while and your nose can handle the extreme changes in temperature. Azelastine, on the other hand, does not require that long wait. It works much quicker. And so you start using Azelastine today, you will feel the full effects of it the same day. It does taste a little bit funny. I don't think the manufacturers have worked on the taste just yet. So I warn everyone that it does taste kind of weird, but it works immediately. Some patients may choose to use both, and that's okay. So they'll use Flonase with Azelastine, and then once they feel better, they back off the Azelastine and keep the Flonase long term.
And are those both over the counter?
They are, yeah.
Yeah.
They are both over the counter, $15 each. They used to be much cheaper, but they're getting pretty pricey now. So
Okay, wonderful. Thanks for that free medical advice. I appreciate that. It looks like we do have another question here, and we will read that here. Dr. Chandra Sekhar, again, would you like to ask that verbally, doctor?
I can do that. So I think
Yeah.
a lot of patients come in with allergic symptoms and, they've tried an antihistamine, they've tried sort of supportive care, and they really want they're very persistent that they want to know exactly what they're allergic to. And I've generally tried to avoid sort of serum IgE testing because just because of the limitations, but is there patients where it would be appropriate to use that as a first line test? And if we do test, is there a specific one at LabCorp, like at SAC Clinic, that you frequently do test?
So when it comes to environmental testing, it depends on the patient. If they're adamant, then I go ahead and order it for them regardless for environmental allergens only. But I give them my little speech also where I warn them that this is not a A1C test. This is not a pregnancy test and you don't know, there's your number, it answers it right away. I tell them that there's a lot of false positive or false negatives and it doesn't change how we proceed, because at the end of the day, whether it's a error allergen or whether it's weather change, it's still going to be the Flonase, it's still going to be Azelastine, and you're not going to be able to avoid it anyway. So for those patients, that's the speech that I give to them before ordering the test. And most will kind of agree. When it comes to food testing, though, that's where it gets really tricky. And I think that's what you're honing in on. Whereas the patient is adamant that it is a food that is triggering it, then I take a brief look at the patient's overall picture. If this is someone who's atopic, there's a good chance that I'm gonna offer a food testing that they'll test positive to, but it'll be a false positive because of their underlying eczema. Then I give them that speech. But if the patient has no atopy whatsoever, there's a good chance that they'll test negative, and targeted testing for that food will actually come back negative and will reassure the patient, and they'll probably stop asking then. So for those patients, I may offer it, but I give everyone the standard speech anyway, that I don't think this is an IgE mediated condition that you have. This test is only for IgE mediated conditions. We can order it, but it's not going to be very useful for you. And then we'll see what shows up. But atopic patients, I try to steer them away from testing. And I have them draw up a list of foods, and then we just order targeted testing instead.
Thank you.
Yeah.
Thank you. And it looks like Joshua Jordan here has 3 questions, which is fantastic. So Dr. Jordan, the first one, the question for Dr. Miot is, what's your go-to second generation H2 blocker for your patients?
I usually go with famotidine, mostly because it's quickly found over the counter. Just like my go-to H1 blocker is cetirizine or Zyrtec, mainly because it's the quick one that you can find over the counter. Allegra doesn't go to the brain at all. So if you're having to do high-dose antihistamines, there's less drowsiness from Allegra twice a day, Allegra 4 times per day. But I tend to go for Zyrtec or cetirizine, mainly because it's really easy to find, and famotidine is really easy to find.
Wow. Okay, great. This next question is, how long of a steroid taper do you recommend for acute flare of allergic reactions?
That is a good question. There is no standard way to actually approach this. Everyone just kind of tosses in the dice and figure out how much is needed. I usually default to 20 to 40 for 5 days, mostly because I tend to be fairly conservative. I don't think they need the 60 milligram of prednisone. I think that's a little bit too much. So I do 20 to 40 for an acute flare of, let's say, rhinitis or something like that. If they're having chronic urticaria, they can do the 40 milligram for 7 to 14 days, depending on the intensity of their symptoms. But I tend to minimize my steroid use because at the end of the day, I'm trying to get the patient to something more definitive, and it acts like a band-aid. So I'm not a big fan of steroids. I try to stay on the minimum end of things.
Yeah, that makes sense. Okay, and the third question is you mentioned that patients on biologics would benefit from getting biologics injection in an allergy clinic due to monitoring. What is the monitoring that you are referring to in regard to the time the patient has to wait and the management of the symptoms that occur?
I want to clarify that a little bit more. So the patients that are on biologics can do that from home. They don't need to be in the allergy clinic. They just need appropriate teaching for self-injection. So those are biologics like omalizumab, dupilumab, and things like that. The patients that need to be in the allergy clinic for monitoring are the allergy patients on shots. So those patients are getting allergy immunotherapy for their environmental allergens. And so those are the patients on SCIT rather than omalizumab. So those patients need to be in the allergy clinic for the shots, and we monitor them for local reactions. We also monitor them for anaphylaxis. So after their allergy shots, they need to stay in the clinic for 30 minutes, sometimes up to an hour for observation, because anaphylaxis from allergy shots can happen at any point in the therapy, whether it's year 1 or year 5. It can happen at any point. So those patients need to be in the clinic for observation after their shot. And we also look at the injection site to see if there's a large wheal and flare, if there's a big hive, if they're developing urticaria or a large local reaction at the site after the injection, because that determines whether we advance to the next step or whether we slow down their dose when they're in the build-up period for their allergy shots.
Fantastic. Okay, does that help, Dr. Jordan? So, did you have anything else you wanted to ask on that?
Small clarification, if somebody develops, say, urticaria from the injection, you wouldn't then label them as allergic, so to speak, to that dose that you gave them, the biologic?
So it depends. If this is a biologic. So again, biologic meaning omalizumab, dupilumab, Dupixent, those types of medications. If they develop a local hive from that medication, which is actually pretty unlikely, I would want to see if this is something that gets repeated the next time. If it happens again and again and again, I would tend to think that is probably a local site reaction where they're not injecting the medication properly and they're getting leakage at the site. That's a little bit different. But if we're getting an allergy shot for aero allergens in the allergy clinic where they develop hives at the site, then those patients, when they come back for their next dose, we sometimes will slow down their dose. We lower it. This is a little bit more frequent because at the end of the day, we're giving the patient something that they're allergic to when it comes to allergy immunotherapy. We know they're allergic to dog, cat, and olive tree pollen. And so during the height of the season, for example, right now is peak tree pollen season. So the patients who are sensitive to tree pollen, they're getting it from outside. They're also getting it in the clinic. And so they will tend to have more local reactions when they come in for their shots. So those patients can experience more symptoms, which is why we want them to be here in the allergy clinic instead. Did that make sense?
It did. And thank you
Okay.
so much for this lecture.
Yeah.
All right, I'm not seeing any other questions in the chat. Would anyone else like to ask anything while we're still online here before we lose our expert?
I'll mention one more thing, 2 things that can be very helpful. If you guys take anything out of this lecture, it's 2 things. Feel empowered to delabel patients with penicillin allergy. That PenFast tool that I shared is excellent. It saves the hospital money. It saves the patient money. It's very safe for the patient. So feel empowered to use the PenFast tool. And as much as possible, if you believe that the patient is experiencing anaphylaxis acutely, you're in the hospital, this is someone who's in the inpatient side, they're admitted, they're in the ER, and you are convinced this is anaphylaxis, grab a tryptase level, because the acute tryptase level is very helpful. This is not something that I'm able to get in the clinic, because by the time they come see me, they are well, and we're trying to catch that acute part. So if they're in your hospital, they are having urticaria, they are wheezing, you are convinced this is anaphylaxis, please treat it with epinephrine first, and then try to see if you can grab that tryptase level within 4 hours of symptoms. It's the test will come back late. That's okay. It'll help me in the clinic. And so as much as possible, that will be helpful.
That's great. Those are great additions. Anyone else while we're online? Yes, Dr. Wolk. And you're on mute, Dr. Wolk. Did you know that?
I was just clapping. That's
just
all.
clap.
Sorry.
You were just clapping. Oh my gosh. Okay. Well, thank you for supporting.
Yes, thank you.
One follow-up question.
Yes, please.
And I'm not turned on my camera because I have a young infant I'm carrying, and I'm trying to keep her
That's
identity
okay.
hidden. But
No problem.
if somebody does present with the anaphylaxis in the inpatient side, we give the epinephrine. My question is there something else we would do, such as when would we do steroid taper? How can you tell what to do next?
Sure. Yeah, good question. So anaphylaxis will always be epi, 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 and then some more epi. Antihistamines are not first line, steroids are not first line. However, if you know that your patient they're admitted because of, I don't know, they're here for urosepsis or something like that, and they were given something that we're suspecting an allergic reaction from, there's no data to support that systemic steroids will help prevent biphasic anaphylaxis. But if you feel like your patient is severely inflamed, they're very, very inflamed, and you think that the steroids will help, talk about the risks and the benefits. And sometimes it's fair to go for it. Is it evidence-based? Not at all. But is it harmful? It depends. It depends. So you treat the anaphylaxis with epinephrine. You can repeat the epinephrine if you need to. And then if you need to escalate with a drip, by all means, go for it. But if we need to add on some steroids and IV Pepsid and IV Benadryl, these are not harmful. So I think they're fair to try. But epinephrine will always remain first line for anaphylaxis. Oh, yeah.
Does that help, Dr. Jordan?
Absolutely. Thank you.
Good.
Wonderful. All right.
I think
Yes.
we have one more question.
Oh, awesome. Thank you, Dr. Palomero. Hello, Dr. Palomero. Can you briefly speak about new antihistamine, Xyzal, and brand versus generic efficacy? For example, Zyrtec, Cetrizine, Claritin, Loratadine, as we help patients and find cost-effective options.
Yeah. I'm cheap. I go for the generic. I have not seen a major difference between brand versus generic, although some specific patients may swear to it. But I warn everyone that, you don't want to break the bank. If anything, you might want to go to Costco and get it in bulk. And because that's usually by the time they're in my clinic, this is someone who will be going through antihistamines quite a bit. And so I say go to Amazon Pharmacy, go to Costco, get it in bulk. They last for a while, and so that's fair. But if the patient is adamant that they want their brand name, you know what? That's okay. Whatever it takes to get you the medication is fine by me. I just say don't break the bank. I don't think it's fair to break the bank.
Okay, that's great. And Dr. Walk, are you waving? Or are you
I am
clapping?
actually raising my hand. So
Yay!
I just wanted to ask. So I know you recommended getting a tryptase level. What does that mean for the patient down the line if the tryptase is
Yes.
high versus not in anaphylaxis?
Yes. So when the tryptase comes back and it's elevated, it helps confirm that we had mast cell degranulation. This is anaphylaxis. Then we go back on the history. Was there a specific allergen? If there was a specific allergen, then we know what this is. We've confirmed this is anaphylaxis. They'll follow up with me for either desensitization or something else, or avoidance. If the tryptase level is low, then we need to think of something else. This was not anaphylaxis. It was a sensation of throat closing, like globus pharyngeus. It was vocal cord issues. It was not urticaria. We need to think a little bit outside the box if the tryptase level is low. However, we in the allergy world are actually now using a formula, because in the clinic, when the patient is well, I will actually get a baseline tryptase level, and I'm going to compare the two. If the baseline is similar to the acute, it's got a pretty good sensitivity where it rules out anaphylaxis, including idiopathic anaphylaxis. But if the baseline is significantly lower than the acute, even though the acute is normal, then I can use the formula. Then we can say, okay, there was anaphylaxis, there was mast cell degranulation. We need to look for idiopathic anaphylaxis. We need to find out if there is systemic mastocytosis, if there is MCAS, and if there is other conditions or a hidden allergen that we may have missed. And so that's the next step from getting the tryptase level. We compare to baseline, and it helps confirm anaphylaxis.
All right, thank you so much.
Thank you for that, Dr. Volk. All right. Anyone else? Okay, well, I guess we will give you all 10 minutes back in your day. Dr. Miot, we want to thank you so much. That was really high level and really substantive, very, very impactful. So we appreciate your time today so much. We know you're in the middle of clinic as you present this. So we really appreciate that. And we appreciate all of you joining us as well. We will be able to send out this recording as well with Dr. Miot's permission, as well as some slides. And we do want to remind you of our next session coming up on May 15th about Medicare wellness checks with Dr. Frank Randolph. That is going to be a really important discussion as well, coming up in just about a month. So anyway, thank you again, Dr. Miot. We wish everyone a lovely Easter and a lovely Passover and a lovely weekend. And thank you. Thank you. And we'll see you all soon.
Yes.
Okay. All right. Bye.